afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on an interesting topic, the impact of COVID-19 on hospital visits or hospital utilization for dental problems in Ontario. My name is Leanne McDonald. I'm a public health physician here at Public Health Ontario, and it's my pleasure to be moderating today's session. I'll start with a few housekeeping items, and then we'll get going. So we have disabled the chat pod for this session. However, you can go ahead and enter your questions in the Q&A pod at any time, and then we will have a discussion and question period following the presentation. So please do share your questions along the way. If you do have any technical issues and need assistance with this during the session, you can email capacitybuilding@oahpp.ca for assistance. And then as the moderator of the session, I would just like to share my disclosures, which are just that I am employed at Public Health Ontario and involved as a participant in CHR and publicly funded research. So before I introduce our speaker for today, I want to begin with a land acknowledgement. We acknowledge that the land we are hosting this virtual educational session on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto, where many of us are based today, is covered by Treaty 13 with the Mississaugas of the Credit. So with that, it's my pleasure to introduce our speaker for today's presentation, Dr. Sonika Singhal. Dr. Singhal is a public health dentist working at Public Health Ontario, as well as the University of Toronto. Her research focuses on understanding and addressing inequities in oral healthcare systems, as well as program design, implementation, and evaluation to gain system efficiencies. Welcome, Sonika. Thanks so much. Over to you.
Thank you, Leanne. Thanks for the introduction. And good afternoon, everyone. Thanks for attending this session today. Today, I'm going to talk about hospital utilization for non-traumatic dental conditions in Ontario during COVID-19. This is the topic. It's not like, since we did this research for the first time, for the last many years, we have been looking at the trends of this, and I'm sure you all must be aware, the audience here, we keep talking about utilization of hospitals and physicians and emergency rooms for non-traumatic dental condition, which essentially means that any dental problems which are related to tooth or gums, but not related to trauma or an accident, because we know that when there is a trauma, somebody meets with an accident and there is a fracture or anything related to like a tooth fracture or a mandibular fracture, then people visit to emergency rooms. But when there is a dental problem, the dentist or the dental professionals are the best to visit, but not to a physician. We all know that. So we have been talking about that for forever, but this time we wanted to look at what happened to this utilization during COVID-19. So that was the subject. And what are the learning objectives here? So we wanted to understand whether the usage of hospitals for dental problems, did it change during COVID-19? And these numbers, this would help in appreciating as how COVID-19 actually exposed vulnerabilities of Ontarians who already face barriers in accessing timely oral health care, thereby increasing health inequalities and inequities further. Apart from that, in very briefly, we will also review and examine some strategies that can help us in understanding what can be more equitable, what we can do in the future to strengthen our safety nets for accessing oral health care. So we all know that good oral health requires timely access to routine oral health care. And we know in Canada that our healthcare system is so that our physician visits or hospital visits are all publicly funded, but not so for dental care, which is majorly privately funded. And that's why affordability to access the dental care becomes a question. In terms of healthcare system utilization for dental problems, there are a number of Canadians who, well, as I said, they cannot afford to visit a dentist for their dental problems. They visit a physician office, or they go to hospital emergency rooms for their dental problems, which we understand is not the most effective way to deal with the problem. And of course, it's not efficient to the system. It's a burden to the healthcare system. Because if they're going to physicians, at best, if there are other problems associated with dental problems, if there are really emergency situations, for example, if somebody has Ludwig's angina or facial cellulitis, for those conditions, yes, at best, medical personnel can help. But at worst, because if there's any dental problem, for example, this pain into sensitivity, we need to do a surgical procedure or do something in the operatory, do some filling, root canal, extraction, something needs to be done, which is not being there. It's just the unnecessary analgesics or antibiotics which are prescribed. So at worst, this can happen that we will be just having more prescription of antibiotics and analgesics to alleviate the symptoms, but we are not addressing the problem. So that's why we do not consider these visits to physicians or ERs as effective or as efficient. Apart from that, dental problems also lead to substantial morbidity. And sometimes then people require hospitalizations because the problems are so severe. And a lot of people we see going to hospitals. So I'm just enumerating different modalities or different avenues where people go for their dental problems. Apart from that, how hospitals are used for dental problems is for day surgeries, operating rooms. In a number of conditions, when the dental problems are quite severe or they are complex and they cannot be attended in routine dental offices, then the patients are advised to be treated in operating rooms under general anesthesia or sedation, and therefore day surgeries are planned. And this is because if in a number of conditions, there can be behavioral complications for which we need to attend patients in operating rooms, but also timely access to routine dental care. Because there was no timely access, the problems have become severe, and that's why it needs to be treated in operating rooms. Especially we can see these things for early childhood caries cases among children from low-income families, or when the availability of dentists are not there in rural and remote regions or in indigenous communities. So overall, the point is that socioeconomically disadvantaged populations attend hospitals more for their dental needs. So what happened when COVID was declared as a pandemic on March 11th, 2020? It directly affected health of people. Of course, a lot of people contracted the disease, and it was a contagious disease. It is still, it's not over yet. So it directly affected the health of people and also impacted the functioning of healthcare system. We looked at trends all over globally. There was a downward trend in ED visits, which was attributed to two factors. One thing was how people interpreted public health restrictions and their fear of contracting COVID-19 when visiting a hospital. And avoiding healthcare for conditions that require urgent care, it resulted in serious consequences. So we know that visiting EDs or physicians or for dental problems is not the most effective or efficient way, but then those people who could only avail services from that resource, how was that affected during COVID, we wanted to see. Apart from that, in general, when dental offices were closed, not just those who could not afford, if the dental services are not available per se, then every single individual universally across the board, we thought that there will be vulnerabilities which will be exposed to receive that emergency care. So how does that affect, and what change do we observe into hospital system utilization for dental problems? That's why we wanted to conduct this study. So we planned a study where we extracted data from IntelliHealth Ontario to analyze ED visits, day surgery visits, and hospitalizations. This included discharge diagnosis for 3 conditions majorly, which is dental caries, and it's just all based on ICD codes version 10, periapical abscess without sinus, and toothache. So the primary year of interest was 2020 for sure, but additionally, we also looked at years 2016 to 9 to see what had been the trends overall in the last few years, and then what changed in 2020. We just didn't want to compare it to one single year. That said, we also assessed the trends by month for the years 2019 and 2020, because not every month was the same. We know COVID started like in 2020, March. And so the initial months, how the trend was, and then did the things change over the time? So we wanted to look by month as well. Apart from that, stratified data by 4 age groups: 0 to 6, 7 to 18, 19 to 64, and 65 plus. So how it was among young children, and then among seniors, we wanted to see the trends by age as well, because we have seen those trends earlier, so it was a good comparator. So in Ontario, for the year 2020, approximately 43,000 ED visits were made, approximately 7,700 day surgery visits, and then 719 hospitalizations. And we'll see how that goes by age groups. So these are the trends from 2016 to 20. For every year, like there are 2 rows, 2016, first row, second row. So the first row for each year is the absolute number of visits. And then the second row is for the rate of visits per 100,000, because that gives us a better comparison across age groups when we have a same denominator. So in general, if you see from 2016 to 2019, it was almost like 390 visits per 100,000 on an average for those years. And if you see by age groups, it is highest for young children, early childhood caries, ECC for 0 to 6 years old, 786 per 100,000 for 2016. And if you compare it for seniors, 210 per 100,000. Similarly, the trend has been same, and we have done these studies previously. Consistently, we see that the maximum number, the rate of visits for EDs for dental problems has been for young children, like 0 to 6 years old. If you see for 2017, 779 per 100,000 versus seniors 211. So by these 4 age groups, in general, we have observed that it is always maximum for 0 to 6 years old, followed by adults 19 to 64 years old, and then 7 to 18 and 65 plus is less at the third, and they're generally similar, 7 to 18 and 65. But then highest for 0 to 6, then 19 to 64. That's the general trend over the years we have observed. And the trend remained the same. If you see in 2020, 459 per 100,000 for 0 to 6, for 19 to 64, 333. And then for the other 2 age groups, 7 to 18 or 65, it's 166. So the trend has been the same. However, the numbers, the rates have drastically reduced, if you can see. So overall, the average was approximately 390 per 100,000, which reduced by almost 100 per 100,000 to 291 per 100,000. And there was a maximum drop actually for young children, 0 to 6 years, which is understandable that for the young children, parents might be very stressed that they don't want to take them to hospital setup. So the numbers must have dropped. If we look at the rates by month, comparing 2019 to 2020, so in March, it reduced, it dropped down, but April was the first month when it was full month closure because of COVID-19. So you can see almost a 50% reduction in the month of April. And it stayed lower for every month in comparison to 2019, although it regained a little bit, but still always less than 2019 months. Talking about hospitalizations in Ontario. So in terms of hospitalizations, if you see, the numbers have again reduced. In the previous years, it was almost 800 hospitalizations per 100,000, which reduced to 719. That said, the numbers remain the same. The rates for young children and seniors, almost 7 per 100,000. Hospitalizations were less for 7 to 18 and 19 to 64 years old. In general, we see the hospitalization reduction for all, but then when we looked at the proportions, it actually increased for elderly. Compared to 2019, the hospitalization rates increased in 2020. That just means that maybe seniors were more vulnerable, had higher problems, more morbidity related to dental problems, and it was so severe that they had to be hospitalized more than other age groups. Going by months, so again, you will see in March, it was a reduction, but in the month of April, there was a big drop. And actually for overall, in the month of May, the numbers increased for hospitalization. That just means that maybe there were a lot more people who were having severe problems to an extent that they had to be hospitalized. So this is something I will say unfortunate or a sad part, an interesting finding for sure, that more hospitalizations were recorded in the month of May. That just showed a lot of more people had severe issues. Talking about day surgeries. So as I described before, that a lot of people who have complex problems, have multiple conditions going on, especially with children who have, it's different for, it's difficult for behavioral management. We do day surgeries under GA. The number of day surgeries dropped quite significantly because they are considered more as elective surgeries. And as you all must be aware, that during COVID, a number of elective surgeries were canceled or rescheduled or postponed because the hospitals were full with COVID patients and the staff was busy handling COVID cases. And if we see here by month, then you can see the largest drop happened in day surgeries. So when almost 1,000 day surgeries are done per month, it reduced to 47. So a huge drop in the month of April, similarly in May, and these numbers remained low. So, recap of main observations. Our results concur with other studies across the globe, which have shown reductions in ED visits for various health conditions, not just for dental problems, but overall, whether it's cardiovascular problems, diabetes, hypertension. There have been a number of studies which have shown the visits to EDs have reduced, and we see a similar trend here for dental problems. If we see May 2020 versus May 2019, ED visits remained reduced by 31%. However, hospitalization rates increased by 31%. And in 2020, hospitalizations reduced for all age groups, but for seniors, the rates actually increased, showing that they are further vulnerable than others. In Ontario, approximately 40% less day surgeries. So overall, if we combine the whole stats for 2020, 40% less day surgeries were performed in comparison to 2019. And this all just reflects a major barrier to accessing timely oral health care, especially for those vulnerable population who needed it the most. Because we can appreciate that people who need day surgery, they must be having multiple problems, severe problems, and that's why day surgeries, like their treatment under GA has been planned. And if they could not receive it, that means that they must have faced further complications. So this just shows more vulnerabilities across those populations. Okay, so lessons learned and possible options as we move forward. We understand that hospital emergency departments are inefficient avenues for handling dental emergencies, as we discussed before. And unsurprisingly, we see that the COVID-19 lessened even that opportunity for such care for the disadvantaged, because that was the only avenue for those who could not afford to go to a dentist. They were going to to EDs in hospitals. And now during COVID-19, even those have reduced. So just exposing more vulnerabilities for those disadvantaged populations. Apart from that, something which was important to understand during COVID in initial months when everything closed down in March 2020, all of a sudden there was no availability of dental services. So not only populations who were finding affordability an issue in accessing dental care, availability of dental services became an issue, questioning the accessibility, and which can happen anytime, even in the future. So I think overall, there is something more to question, that not just for one specific population, but overall, as a universal matter, we need to find avenues where at least people can access emergency and essential dental services, if not everything. On that note, just a suggestion, I'm happy to have this discussion further. We know that there have been a lot of discussion going on about the National Dental Care Program, how this is going to be launched, but can there be something about universal emergency dental services? Yes, that's targeting more for $90,000 and less, like families of income less than 90,000. But how about having a universal emergency dental services for all? Because a problem like COVID exposed vulnerabilities for all populations, irrespective of their age, sex, demographics, socioeconomic status. If there is no availability of dentists, then how would they avail services such as emergency services? Apart from that, can community infrastructure be strengthened? Whether it's public health units, whether it's academic settings, can community infrastructure be strengthened so that we have more availability of emergency dental services, where we have dental professionals to deal with dental problems, not non-dental professionals, where we are just seeing prescription of antibiotics or analgesics, but no dental procedures to take care of the problem. So some food for thought, and I'm looking forward to your questions and more discussion around this. So thank you very much.
Thank you so much, Dr. Singhal, for your presentation. So we'll now shift into the discussion portion of today's session. And again, invite you to enter any questions that you have into the Q&A, and I can read those out and bring them forward for Sonika to consider and discuss. Okay, so I see some questions coming in. Thanks. Please do keep sharing them. If you are thinking of the question, others likely are too. And so it's a good opportunity to share. So we have a question about future trends. So what do you project will be the future rate of non-traumatic dental conditions due to decreased availability of preventive care during the pandemic?
I think that's a good question. what I can expect is that, of course, I'll be interested in looking at more trends in the future, but probably I'm not going to see any reduction. That's what not I'm anticipating, any reduction in visits to EDs or physicians. As you rightly said, that there's less focus on preventive care or a public health, a population-based approach on preventive care, but more on clinical care, more restorative care. So until the time we do not have more preventive strategies in place, the incidence of dental problems will keep happening, and people who are not able to afford will keep visiting EDs.
Thank you. So we have a couple of questions that are continuing in terms of looking to additional years of data or thinking into the future, but particularly noting that your project focused on 2020 and comparing to years leading up to 2020. Have you considered looking at similar analyses for 2021 and or 2022?
Yes, I am planning for doing that analysis in the future, not in the next few months, but definitely that's in the pipeline. I want to do that.
Mm-hmm. And do you have any comments on what you would expect to see for those 2 additional years during COVID?
See, in general, what other resources say is that overall, because there was a big drop in dental services utilization in 2020, but then through some other data, but then after that, it has revived back, and dental care utilization is going back to normal. So I will see it will go back to something numbers before COVID. That's what my expectation is. We may see increase in hospitalizations per se, but for EDs and physician visits, it's gonna be just coming back to the pre-COVID era. That's what my anticipation is, but only numbers will tell.
Look forward to seeing some further analysis then. We have a comment, and I'll try to sort of tease out the question from it about OR time for dental services and how that might be a factor in particular in respect of seniors. And I wondered if you wanted to comment on that in terms
Sorry,
of.
I didn't get the question. Can you please repeat that?
If the context of operating room time available for dental services, particularly for seniors, is a factor in understanding the patterns that you observed.
Unfortunately, we do not have any data like how much time is required, like OR time per se. It's more about the procedures overall. And then, as I said before, the trends have always shown that it's for maximum for 0 to 6 years old. So I'm not sure if we can, predict anything based on that.
Thanks. We have a question about just understanding costs associated with day surgeries for non-traumatic dental conditions for children. Wondered if you had any insight into that.
So numbers might have changed as per the latest data, but then few years back we did some analysis, and it was approximately like $1,500 per procedure, and that was excluding the cost of human resource, just the operatory and the hospital cost. So we did some analysis earlier, and it came to be like approximately like $13 million per year for day surgeries in Ontario.
Thank you. We have a question noting that it would be interesting to understand the patterns at a sub-provincial level, so by municipality or more local jurisdiction, and understand any differences. Is that something that you could comment on, or speak to whether there were plans to look at different area levels?
I completely agree, because there is so much variation across our health units in Ontario. And we did some analysis earlier, not for COVID, but earlier some trends. And we did see some interesting differences across health units, especially like Northwestern health units. In northern regions, we saw more visits. So I think it would, especially for day surgeries, more day surgeries in northern regions and versus urban health units. So we did consider, but we couldn't get that data, like clean data for that. But in the future, when we are planning to do for 2021 and 2022, so that's a good suggestion. We would definitely try to consider that we do it by health units.
Thanks. So there is a question about whether there are any other data sources that could be used to assess potential morbidity associated with not being seen in hospital for dental issues during 2020. And I presume this is kind of thinking about some of the month-by-month trends you presented. So I don't know if you could speak to what you think did capture morbidity in your analysis and what other potential data sources might be to examine this.
See, in general, it can be done. I mean to say, I don't know how much I can discuss the whole methodology here. So for hospitalization, this is like, in general, it means if somebody was hospitalized for a dental problem, it would probably that a severe dental problem. But then other morbidities related to dental problem, and if I'm understanding where you are directing, it may be that, periodontal problems with diabetes or cardiovascular conditions. So if we want to see that kind of morbidity related to dental problems, we need some longitudinal data. We need to know the oral health conditions of that person, data linkages with ICS. So some like studies related of linkages with ICS data can predict better about the actual morbidities associated with oral health problems. But with this data, it's very difficult because it's a cross-sectional thing, like administrative data at one point of time is just using the ICD codes related to dental problems. So it will be a different study design, not with this kind of data.
Thanks. Another data source related question is related to the variability of dental services available in hospitals and whether and how that might have influenced the data you had available to analyze.
So this is for all of Ontario, irrespective, like it's not only few hospitals versus another. So it's giving the snapshot of whole of Ontario, in my understanding.
Thank you. We have another question that's about trends that were observed elsewhere. So outside of Ontario, I know that you presented some high-level global highlights of some trends of ED visits, but do we know what the observed outcomes were across Canada or in other provinces? And a second question is, are any other jurisdictions undertaking the same type of research or studies as you have?
Not I am aware of. It's like related to COVID. We have data of trends in ED visits for Alberta and BC in general. That was pre-COVID. But looking at the impact of COVID-19, I'm not aware of any other jurisdiction doing this kind of analysis.
Thank you. Do you have any additional insights you might be able to share into the different trends you saw with seniors in this study? Any other hypotheses about how to interpret what you observed that was unique to seniors?
The only thing which was unique to seniors was more hospitalizations related to dental problems, and that was interesting. And we could see how it makes sense because seniors, especially with more morbidities in general, more fragile. So if they had like dental problems which were quite severe, then might be they got more hospitalized because of their dental conditions, which became quite severe. And also, as I said, that it's not about just people who could not afford. There might be people like senior people in the society who may be able to afford, not low income, but then because for more than 2 months, there were no dental offices to provide dental care. So during that time, even those who had never visited an ED before, because they were going to their routine dental offices and they were shut down, if their problem had aggravated, they they also might be visiting. So the patient population who was earlier going to hospitals, it was not just that population. The anticipation is that more seniors from the society who had no affordability issues, but because of non-availability, they also might have had aggravated problems and could have hospitalized. So we cannot see the socioeconomics here in this data, but that would be the assumption.
Thanks for sharing that. Can you comment on opportunities that you see on the horizon for increasing access to dental care?
They can be, for sure. I mean to say, we all need to come together, like more discussions around it, that how our infrastructure can be more strongly built, that at least we can take care of emergency situations that can be more universal and not just pertaining to one population versus another. See, with dental treatment, it's not about yes and no. It's not about like one treatment, who you are targeting, who you are not targeting. There's so much variability across the dental treatment services. So forget about the more restorative part or preventive, but at least for the emergency services, something like this, we need to have stronger safety nets.
Thank you. I have one more question, and certainly would encourage if others do have more questions to add them. But knowing that we often have local public health audience members for PHO rounds, are there any implications that you would wish to highlight that would be particularly relevant for local public health units and their work in the area of dental or oral health?
For sure. I mean to say, in general, the public health units are doing great. They have their own data. They understand their context the best. So, and I know there are like some of them are doing a lot more than others. So it's quite discretionary. So I think it's not on me. It's they know the best what they're doing, and they can take care accordingly, looking at their own data, like whom to target the most. So I think it's back to them.
Well, thank you so much for your thoughtful responses to questions from our participants. It was great to see many participants today join our session. Thank you to Dr. Sonika Singhal for sharing her expertise and the findings of her analysis. And thank you to everyone who made time to join us today. We do encourage you to complete the survey that allows you to give us feedback on today's session. We use that to improve our programming. And if you're interested in past or upcoming opportunities to participate in PHO rounds or learn from the resources, you can look at the PHO events website. So again, please do share your feedback via the survey, and thank you again to our speaker today, Dr. Sonika Singhal, and have an excellent afternoon. Thanks, everyone.
Thank you, everyone, for being there. I really appreciate it. Take care, everyone. And thanks, Leanne, for moderating it. Thank you, everyone. Bye for now.